Hi, everyone, and welcome to episode 22 of the HCBiz show. We are coming at you with another startup showcase this week. We tried out this format for the first time last week and had some pretty good success and good feedback. So we've got a couple of these coming up, and we're trying again today. So we are also operating at a special time. Every other the previous 21 weeks, we've been at noon Eastern. So we kicked off the tweet chat at 3 Eastern today. Hopefully we'll get a few more West Coast folks coming in to see the blab this week. And on the line here, we have Niall Wallace, who is the CEO and co-founder of Infonaut, and Dave Thiemecke, of Managing Director of VCAMP, and of course our co-host Shahid, Shah, CEO of Netspective, here with us as well. So welcome, everyone.
Thank you.
Today, we're going to be talking about a very important issue, one that's been being worked on for years and years, like many things in healthcare, and that is namely the hospital-acquired infections, and often rolled under the terms of healthcare associated infections. Thank you. I tripped all over myself there. Healthcare associated infections. And Niall and company at Infonaut have been working on this for years, and we wanted to tap your expertise and your learnings over the past, I don't even know how many, but many years that you've been working on it, and that'll be the basis for our show today. And Shahid, I wanted to give you an opportunity. You usually have a pretty good way to frame up why these issues are important and what we're after in a show. So I'll give you the opportunity to do that here.
Great. Thanks, guys. Niall, welcome. I spent a little time in the AI world as well, working on what in the old days were just basic pattern matching and trying to understand where infections were sourced more than anything else. So the idea was to put systems into place where you could find out if infections are occurring. Obviously, you need to take care of them, but more importantly, where were they occurring, and whether it was a training issue or whether it was equipment issues, cleanliness issues. Obviously, everything boils down to some level of sterility somewhere. So I'd love to maybe frame this around is what is it about either digital health or the techniques that you're using today that are different enough than what we've used in the past with respect to understanding either the source of HAI or meaning from a diagnosis perspective or the treatment side. So tell us a little bit about where you're focused on and how some of the modern digital health tools, capabilities, integration, and other things are more successful today than they would be in the past.
All right, very good. Cool. So to dive into that, I want to just take a step back to frame up the problem a little bit, and we'll go right to you, Niall. And really, what I'd like you to tell us is why is this? What is the problem that you're attacking? Why is it important? And what do we stand to gain by solving this issue?
Sure. Thanks for the opportunity to speak as well. Hospital-acquired infections or healthcare-associated infections, which I believe is a new term that's been introduced as a way to obfuscate the problem. It basically comes down to patients going into a hospital or healthcare facility for treatment of one ailment or another, acquiring an infection while in that hospital environment, and then suffering from that infection and the consequence of that infection during the rest of their hospital stay or after they've been discharged. It affects patients, and I think CC reports that maybe 1 in 25 patients that go into a hospital for treatment are leaving hospital. There's some data saying that workers' compensation and short-term disability claims in hospital environments is about 40% higher than the outside world, but there's no hard data around that. That's an incredible number as well. And if it's affecting patients and it's affecting workers in the environment who are healthy, it's almost certainly affecting visitors and other people coming into healthcare environments. But there's absolutely no data on that at all. So massive problem. I think I would put it up there in terms of climate change, in terms of, if there's something that's going to kill us all, it's going to be antibiotic resistant bacteria, viruses, and bugs that are primarily, the virulent ones are contained and or grow and become worse inside hospital environments just because of it's the nature of the beast. Lots of antibiotics spreading around, lots of sick patients, and ample opportunity for those diseases to move around. So, I mean, in terms of costs, even though I think it's underreported, the estimates are about 99,000 people per year in the United States die from 1.7 million getting sick. And to put that in some context, I think that is equivalent to, a jumbo jet or a New York, LA flight crashing every single day. And you can imagine the outcry if that was happening every single day. And we've seen a lot of estimates in the costs that this has on the system. And it's very complicated, but it has been estimated as high as $45 billion annually on the hospital systems. And that's an incredible number. It's probably a little bit lower, but those are the numbers that are out there from people who study this in a great degree.
Gotcha. So it's not just a cost issue. It's not just a patient safety issue. When you start talking about, antibiotic resistant infections, that's a much bigger deal. And that's, I'm glad you brought that up because that was something I hadn't been thinking about at all. And you mentioned
absolutely, it's population health, public health. Right. Infonaut got their start because we were witnesses on the, close to the front lines of SARS in Toronto. And a lot of people don't realize that, it's a very contained event that we got our heads around after the second wave. Should that have expanded, that was a warning of what was to come. And when these bugs and these viruses and these illnesses get into the population and you don't know how they're spreading and there's no way to stop them, then you're in a situation that would resemble something like the Spanish flu, which, was, 1918, which was an absolutely horrible cataclysmic event. And it may be worse the next time around.
Right. Gotcha. The other thing that I thought was really interesting there, and I hadn't thought about before the tweet chat today, is the idea of the visitors becoming infected. Somebody on the tweet chat actually said that they contracted MRSA while visiting their father at the hospital after the fact, after they had a surgery. So I, again, was focusing on patients and, certainly hospital staff, but yeah, absolutely. Anybody entering that building, if there's a risk, is put at risk.
Yeah, and an easier way to understand this, and we always try to drill down to root cause analysis when we're trying to kind of devise new ways of approaching this is, the hospitals as a building. If we were to take a step back and say, let's invent the best way to spread infections. Let's build a building, make it fairly contained. We'll put lots of sick people in there. We'll move them around. We'll give them lots of touch points. We'll have people coming in from the outside world, visitors, kissing them on the mouth, taking their hand, lots of dirty things moving around. As you go down the list there, you realize that, hey, that's a hospital. And until we start treating those environments with the respect they deserve because of the danger and risk around them, I believe the problem will just get worse.
Yeah, that's a great point. And then the last thing that you mentioned and kind of your setup there that I wanted to ask you about is, 99,000 a year by those estimates of people that are dying as a result of this. I've heard the jumbo jet example laid out all over the place. Why isn't this a bigger issue? Why aren't people talking about this outside of, these types of circles where we spend all of our days talking about things like this? Why isn't the public talking about it? Why isn't the news picking up on it? They love talking about tragedy. Why don't they care?
And I think it does get some coverage, but I certainly, I think, share the sentiment that it's a difficult topic to cover and it's difficult to wrap your arms around. I think the most obvious one is these things are invisible to us. We can see crashes on TV. We can see other types of dangers. We can see things that are very physical in front of us, and we can take necessary precautions. But when something is an invisible killer, it's much more difficult to wrap your head around. And these infections and viruses are very smart. I mean, they are, the domain that we really don't have control over. We liken them to running water. Is if you find one way to address them and block them, much like running water, they'll find a way around. So the fact that you can't see them, the fact that I think it is a horribly understudied area in terms of evidence around how they are transmitted and move, which really has created the space for groups like Infonaut. And the fact that it's multifactored, and it's very difficult to describe how somebody gets sick. And if somebody does get sick, you go, it could really come from anywhere. Makes it a very difficult challenge to kind of put your thumb on it and describe to people. It's not one issue that we can kind of point to and say this needs to be fixed. In fact, the attempts to do so really have resulted in the World Health Organization, as an example, putting out the 4 or 5 moments of staff hand hygiene compliance. We're going to dumb it down to getting staff to wash their hands better because they're the one people we can point to and blame. And I believe over time, we may look back on those types of initiatives and see it for the public health tragedy that it is. The World Health Organization has actually contributed to the problem by trying to dumb it down, to try and create some obscure measures, and then lay the blame at the feet of the frontline clinicians, which is an obvious mistake, regardless how you look at it, as soon as you have a little bit of evidence in your hand.
Well, that's really interesting. Now, I assume you're familiar with it. There was a few years back that Atul Gawande, writes for New York Times or New York Post, I believe, had a whole piece about, we've got this checklist, and basically if you wash your hands, you're going to lower. It was a very specific infection by some massive amount. And the whole point of his piece was that it was something that's straightforward, but it was hard to get people to wash their hands. Are you familiar with that story at all from a few years back?
Yeah, and I'm very familiar with, the checklist manifesto. I certainly see massive advantages to having that. The challenge in what he describes is that you start with an assumption that staff washing their hands are going to make things much better, and I believe that is incorrect. I think some environments are different than others, and some staff are better than others. But as we look at the challenge, I think we may be close to what we call peak hand hygiene. There is gradual improvements to be made with that as the singular focus. And again, I think it lays it dumbs it down. It removes all clinical judgment from some very smart people that are right on our front lines in charge with keeping people well. And it ignores the obvious. And I'll give you one example. And we're big fans of root cause analysis. I believe the infection that he was talking about, referring to, was C. difficile. And I may be wrong, but I think that's correct. Okay. C. difficile, who makes the patient's, comes from feces and eventually makes its way to the patient's mouth. And then when you stand back, you look at the problem, you go, well, who's putting their hands in the patient's mouth 200 times a day? And it's the patient. Now, the patient has an opportunity to pick stuff up from the hospital all over the place, especially if they're mobile. And, we can measure the number of different people coming into somebody's room. There's not a hospital that I'm aware of that has a patient hand hygiene protocol or compliance standards, right, or make sure that the patient is washing their hands. There's a lot of evidence out there that says if you want to really tackle C. difficile, you introduce patient hand hygiene. That's a very difficult thing to sell as a concept to a hospital, because we've been talking about it for a few years, and I haven't seen anybody kind of pick it up and run with it properly yet. Yeah, right. Gotcha.
Yeah, just a quick note there. So when you look at HAI, whether the old term hospital-acquired infection or the healthcare-associated one, Niall, how do you split up the idea of superbugs, which are coming because we see a lot more of these infections and they're becoming more and more resistant, versus just a traditional, what we've seen in the past of hospitals and other health systems not properly managing infections within their organization, because those are two different kinds of things to look at. And then somewhere in the middle is this idea of we've made some strides on the healthcare workers. Now let's move that over onto the patients as well. And I've actually seen a few signs and folks talking with in certain of the hospitals that I visited, where they've started to talk to their patients to say, you know, when you go to the bathroom, do this, when you do that. The signs, the order signs still say nurses and doctors must wash their hands, like somehow, you know, patients shouldn't be washing their hands. But the question of the superbugs and what you're thinking about infections on that side versus the traditional HAI, do you see a difference between those two? Or are you really focused on HAI traditional? So Niall, that was for you.
Hey, Niall, did we lose you?
No, so I can't hear Shahid,
Okay.
but if you can repeat the question, I'll jump in.
So Niall, can you hear me?
No, I physically can't hear Shahid on the.
Okay,
You'll
gotcha.
have to, somebody else will have to
I
repeat the question.
misunderstood that. Yeah. So basically, he was asking you to address the difference between a bug that's being not taken care of properly by the hospital, and that's why it's spreading, versus a superbug that we don't have a good way to combat it. Two very different things. How do you view those differently from your work and from the hospital's perspective? I hope that was about right.
Yeah, I mean, when we look at infections in hospitals, we quite rightly identify prevention and control. Prevention is stopping somebody getting sick. Control is, the horse has left the barn and somebody is sick. Or you're in an outbreak environment and you really need to rapidly stop any kind of spread. Listen, the path forward is in prevention. There's very little new antibiotics coming down the pipeline. We've already used up many of the big guns that we have. We're seeing things like hospitals in Pennsylvania, which is not so far from where we are in Buffalo, are seeing cases that are totally resistant to all antibiotics that are available. And frankly, if some of the more virulent superbugs that are close to antibiotic resistance, the result is if the patient survives, life isn't very good for them after that. It's a very, very painful existence from that point on. So I think it's valuable in looking things at prevention and control. The emphasis certainly has to be in prevention, but we recognize the challenging environments the hospitals are under and that people do get sick, and that the control aspect has to be closely adhered to. And frankly, control is easier. If somebody does get sick, we know that we should put them in isolation. We know there's certain protocols. We know there's certain drugs that may work, or there's tests that can be run. And there's more that's understood on the control side. The prevention side, which is ultimately the path forward, and where I believe that hospitals should be measured as an outcome going forward, is that they are getting better and better at what they're doing, and there's less and less infections. As a rate, and how you standardize that over time is important, but they're getting better at what they do on the prevention side. And really that is the only path forward, because I don't think anything's stopping the growth in antibiotic resistance. We don't believe there's any new drugs coming down the pipeline that are going to make a measurable difference. And it's a challenge that, is going to be one of, ultimately survival for the hospitals and the hospital systems themselves. But it's also corresponding to a move around population health where, people can't be in hospitals as much as they were before. One, because it's not the most efficient place to treat them, but two, they just won't be able to go in for non-elective surgeries, simple surgeries, because the risk to their health is too great. And the UK, who's a leader in this space, has actually said that is most probable eventuality is within 15, 20 years, perhaps even sooner, that people just can't go into hospitals for surgery. It's not safe.
That is a scary concept for sure. So that's perfect segue into the some of the topics that you addressed in a white paper that you guys released recently. CMS, CDC, they're pointing to some numbers that are showing that since 2008, when CMS stopped paying for certain HAI conditions, things are getting better. And I think the most recent data was from 2014. They released a study this year, and they're across the board showing that things seem to be getting better. What are your thoughts on that?
Well, I think that the most accurate representation of success in the since 2008, since the penalties came down, is from the Government Accounting Office, the GAO, and I would point to an excellent synopsis by Leah Binder, who's the CEO of the Hospital Safety Foundation, or the Leapfrog Group, which publishes hospital safety scores every quarter, and they do a wonderful job of really kind of creating a consumer view on how safe hospitals are and their efforts to keep patients safe as a way to make a more informed decision. And she said three things. After 20 years in the space, and after all this study, and after the Government Accounting Office, reviewing all of the actions, there's three problems that she saw. Hospitals still can't find the problem. Should they find the problem, they can't solve it. And should they solve it, it doesn't really matter because people aren't doing what they're supposed to do anyway. And that was a very insightful sum up, I think, of what the Infonaut value proposition is. We've spent a lot of time figuring out how infections move in hospitals and how to stop them. And we've made that link to institution. I would add a fourth to that. After spending time working with insurers and experts in the space and studying the data, we think that the fourth point there is that there is a misalignment of incentives and who is paid and how they're paid, which is obfuscating the problem and creating a data issue. I'll give you the examples that I've seen. Stanford University did a paper, I think about 6 months ago, that said infections are falling because hospitals have figured out how to upcode. Now, the financial lever that CMS pulled and the insurers followed said, we're not going to pay you for the four most costly or most pervasive infections, and those are C. diff, MRSA, cauticlapsies, and MRSA SSI infections. We said, we're not going to pay you. So somebody comes into your hospital, they break their leg, you get paid for treating someone's broken leg, but should they get an infection, one of those four infections, we're not going to pay you. And those financial costs for a hospital can range anywhere from about $1,500, but average about $9,000, as high as about $100,000 per case. And so the hospitals took a step back at that point, and I'm not saying it's fraud, but there's an element of fiction to it, and Stanford put some numbers around it. Is hospitals found ways to code or upcode what the condition was, so that while treating the infection that may or may not have occurred in the hospital, they were getting paid for a higher value DRG. And in doing so, they recovered a lot of the revenue that they were losing. So in the plain numbers that were being reported, you saw a drop in those four infections. And you can declare success. But when you looked at the data, it didn't match what the success was being reported as. Secondly, and I think something that really interests us and something we're doing more work in is sepsis, which is an infection classification at a very general level. I mean, most infections, or a lot of infections, result in a bloodstream infection, which is what sepsis is. Sepsis was not included in those that don't get reimbursed. So we saw a massive spike in the amount of sepsis being reported as a DRG code, all the way to the point where I believe it is the number 4 DRG code in the United States. And we've seen some data around that, and I think that bears some closer examination. But all of a sudden, we've uncovered, or we've entered a sepsis epidemic, and totally unrelated to those 4 infections that the hospital's not getting paid for. Now, we're an evidence-based organization. We would want to present this type of argument with more evidence, but we're at the beginning of that journey. But all signs report to others who have studied the area and our own findings that the numbers haven't decreased. They've just found a different way to report them. And primarily that was financially driven. Hospitals are not being rewarded or reimbursed for those infections, and so they found other ways to code around it, which creates a massive challenge in the industry. If you were a hospital that is really dedicated to reducing infections in your environment, and that is your sole focus, while you're reducing your direct costs, you're probably also seeing a corresponding decrease in your revenue, because those are items that are no longer being charged, that you're receiving revenue from. And you're certainly not receiving those kind of payments from the government through the various sources. And the penalties you may avoid, which can sound significant when we say $1 million per hospital, are probably a small drop in the bucket compared to the overall loss in revenue from being the safest hospital on the planet.
Yeah, really good point. So I'd love to keep digging into the problem. We're hitting about the halfway point, and I want to start talking a little bit more about specifically what you are doing at Infonaut. How are you attacking this problem? What is your offering? What do you do?
So, Infonaut grew out of the SARS crisis, and our goal when we started was we wanted to become experts in disease surveillance through the wider world. And we built some outstanding applications way ahead of their time, web-based, looked like Google Maps before Google Maps was available, that provided a way to observe and track infections and figure out how they were moving through communities. And we got to the point where we were doing this at the genetic level based on lab test results. And so we could follow a case by its genetic markers and match it or to other cases in the community and give that information to public health front lines and let them figure out on the ground how that case transmitted from one case to another, from a neighbor to a neighbor, or across town, or even across the province. At some point there had to be some direct contact involved, or very near contact. And public health is not an excellent innovation client. So as a startup, we were looking at an award-winning application that wasn't really generating the revenue we needed or getting sort of the attention from the marketplace. And at the same time, we were invited into a hospital that was undergoing a C. diff crisis, 120 cases, 22 deaths inside of 9 months. And we went in and we asked ourselves, and quite naively, because we had a quick look at the academic literature around it, we thought it was thin. We asked ourselves the question, how are infections moving in a hospital? Because the challenge was that these cases were popping up all over the hospital and nobody had an idea how to stop it. They're all washing their hands like crazy, or as they said they were. We came to the conclusion in the hypothesis for the company that infections move in a hospital because people move them. Now, that is a very simple statement to make with huge ramifications. For us to better understand infections in a hospital, we studied the hell out of hand hygiene, and nobody did it better than us, and we still do it. But we realized that we had to become experts in measuring behaviors in the environment, in the hospital environment, that would probably contribute to the spread of infections. And we knew that we had to stop just measuring staff, that we had to focus on patients because they were getting sick, and visitors as well. And so we took all of those measures of movement, contact, interactions, and that's really where the patents lie for the company. We boiled that down into measures of behaviors. And by over time and seeing who got sick and who didn't, looking at risk profiles of patients and really sort of trying to do that root cause analysis and then tracing infections after the fact. How did John Doe in room 12 get a case of C. diff, and tracing it back to what would be sort of ground patient zero, and looking at all the interactions and behaviors between them. We developed a methodology to risk, rank, and prioritize those behaviors that are most likely to spread infections in hospitals. And we went, yay, okay, we've got something very important, but we were missing the so what. And this is sort of, the entrepreneur 101 is, it wasn't just enough to be able to measure those behaviors. If we wanted to really be part of the solution, we had to stop infections happening, which meant that we had to change behaviors. And it was very difficult for a company that, a bunch of IT professionals and, people that consider them experts in kind of flow inside a hospital, to turn their attention to behavior change, which is, everybody in IT knows is probably the most difficult thing to do. It's certainly something that hospitals haven't been really successful with in the past. So our offering now is to the point where, we measure a baseline of behaviors inside a hospital between staff, patients, and some visitors. We know, and we believe that we know better than anybody which are the highest risk behaviors and which ones need prioritized and should be changed. And then we have a set of what we call psychology compliant interventions. So we know that we have to get to behavior change, and so we work our way down the list. If X, Y, Z is the problem, then we have something in our toolkit that causes an immediate, sustained, and persistent change in that particular behavior. There was a point where we were going into a hospital and throwing everything at the wall. Like, let's just get behavior change, and we don't have time to sort out what works and what doesn't. We throw everything at the wall. We're a little smarter than that now, but we can come down the list, and as soon as we have that baseline of behavior, we can make the changes, we can measure success, we move on to the next one and the next one. And so that's the easiest way to explain. We have a healthcare IT platform that takes in a lot of movement, contact, and interaction data. We sort it, we prioritize it, we risk rank it, and then we're really smart about introducing interventions that change behavior across all the groups that make sense.
Niall, a couple of questions associated with that. So in the past, the kinds of things that we've spent time doing on the health IT side was to investigate sources of HAI based on lab values. For example, if you were testing patients for labs over the course of a week, and certain labs were seen that were indicative of infections, you'd go find those patients and say, well, why are these patients getting certain kinds of infections? Then there were connections to HL7 and other mechanisms that we were able to do telemetry and figure out what staff were doing, what were they assigned, which rooms they were assigned to, and those kind of things. So it sounds like one is not necessarily better or worse, but it sounds like Infonaut is more focused on behavioral understanding first before making modification. But are your behavioral understandings emerging at all out of electronic health records, labs data, or any other hospital systems? Because that's where we found a lot of trouble in the past, whether it's sepsis or HAI broadly, is getting these systems integrated into hospital systems has been tough. So it sounds like you don't need to do that in order to.
Were you able to hear him that time, Niall?
I was not. If you can repeat it, I'll try and answer.
I don't know if I'm quite able to repeat all of that. Dave, how much of that can you parrot that back?
Yeah, one of the hardest things about adoption. So this is how I heard Shahid. One of the hardest things about adoption inside of a hospital environment is, hey, you have to tie a lot of different systems together, but you have to make it an easy path to bringing them all together to make the kind of conclusions you've already been able to make. How have you been able to overcome that?
To be honest, it's a challenge we're still addressing. I'll reflect on our business model and our choice on the business model. So right now, our target is definitely selling to hospitals. We realize it's a challenge working with hospitals on the adoption side. And so we've also started working with the insurers, and we've written a paper about why we believe the insurers are actually the biggest beneficiary of safer hospitals. But our business model, as it currently stands, is we've de-risked it for a hospital. We will go into a hospital at no fee. We will deliver on the value proposition of better outcomes, which is reduced infections from a 3-year historical baseline on a unit-by-unit basis. And then if there is an upside and there's a decrease in infections because of the work that we've been involved in, we will take a percentage of those direct cost savings. And that almost turns out to be a negotiation on a hospital-by-hospital basis. But we realized that there's a huge opportunity for us, and we also de-risk it for hospitals. As an innovation startup, we cap it as well. It's like, if we're wildly successful, we're not going to take $10 million out of your account. We'll cap it at a certain amount, which pays us for our time quite well. But we don't want to take any money from a hospital unless we're successful. And I believe that's a very important model for other startup and innovation companies to follow. One, effect on outcomes. What are you doing in the space? Are you really differentiating yourself that much, or are you delivering innovation? The second is that you have to quickly get traction in the market with a new concept and new ideas. The average sales cycle in healthcare is 18 months to 24 months. A lot of startups can't survive that length, and they look at things quarter by quarter. And it also aligns ourselves with where the market is going. Insurers are now forcing hospitals to enter into what they call shared savings contracts, which is, like ACOs have been designed, is we'll pay you so much for the challenge or what you're trying to accomplish. But those savings really have to be realized and shared between the different providers involved. And as a vendor, right now, I do want to be seen as a partner in the process, and I want to take a share of that risk. In fact, we're taking a great chunk of the risk. We're very confident that what we will do will have great effect. We've had case studies out there where we were reduced within 1 year all of the causal factors. So you want to improve hand hygiene, done. Do you want to make sure the environment's cleaner? We can do that. But really, the outcome is reduced infections across the board, not just with the 4 that you have to report. We've had great success in that. We've had great success in reducing the cost to a hospital. Our challenge is, and what we've discovered recently is, while we were being so successful in those areas, we may also have reduced their revenue. And that is a challenge that is going to be tough to overcome in a wider market, but there's still a lot of hospital innovation adopters out there that we do want to work with, that do see the value for the brand and for patient safety, and are willing to work with us to figure out what is the best financial model for them going forward, and then how do we incorporate the insurers into the conversation too.
All right. So let's talk about that a little bit. You mentioned in passing there that you felt like the payers and the insurance companies were some of the best, would be the best beneficiaries of decreased risk of infections here. Talk about that a little bit.
Sure. When we look at the ROI, I talked a little bit about the challenge in the hospitals and really, a possible impact on the revenue side. But let's say, Dave's on the line here. Let's say Dave is in a hospital, to get his broken leg fixed. He requires C. diff, which means he's in hospital for 9 more days. So the hospital's going to get paid $5,000 for his leg. They're going to lose out on $9,000 or $10,000 on him because he's a C. diff case, and it was determined that it was acquired inside the hospital. So the insurer doesn't pay the hospital for the $9,000. However, Dave, who survived C. diff, is now in the community for 3 years. He's taking broad spectrum antibiotics and various other drugs. He's receiving a great deal of primary care. He's receiving a great deal of home care. He's probably in some therapy and rehab for that, all of which is covered by the insurer to a great degree, depending on the plan. Speaking as a Canadian here, but one that knows more about the U.S. model. So when we break down the costs, or the cost to an insurer over a longer period of time, health insurers measure their primary metric inside that they try to understand is called PMPM, or per member per month. What is it costing them per member per month versus the revenue that they're getting off premiums? And health insurers live on a fairly thin premium, and so it's they really can't take too much of a hit. And as well, with the premium increases, there's not a whole lot of latitude to increase the premiums to create better margin for an insurer. So they really have to be focused on the cost, or their PMPM member. Now, if Dave is a member of a cohort that has caught C. diff in a local hospital and is receiving that type of treatment over 3 years, which is going to be far in excess of $9,000, they now have a fiduciary interest in ensuring that the hospital they're sending Dave to get treatment in is not going to make him sick, or at least fewer cases than the hospital down the road. They have a fiduciary interest and a financial interest in ensuring that Dave leaves healthy, and that he is his outcomes are positive, and that if he does acquire an infection, it's dealt with very quickly and rapidly and responsibly, and it doesn't result in, Dave showing up 30 days later in the ER saying, I am not well, and things have gotten much worse. So when we've talked to insurers about the challenge, I mean, they certainly realize that the costs are on their side. What they haven't been able to do because of the challenges around the data is really kind of isolate that cohort and saying how much they're costing us. I think we've provided them with the methodology to do that. We will continue to work with them on that very issue. And part of our role and responsibility now in growing the company and looking for stronger partnerships in insurers is helping them understand their ROI. So whereas a year ago we were spending so much time and effort on understanding the hospital ROI, we spend more time these days engaging with the insurer and trying to understand where their costs come from. And I will say as well, something very interesting came out. We started meeting with Zurich, who is a partner of ours on the property and liability and workers' comp side. And while they insure a hospital for property, part of that is business interruption. And the example that was raised to me was that hospital that had the one Ebola case as an extreme example in Dallas. Went from 80 or 90% occupancy to nearly empty for 6 months, and then was stuck at a 30% occupancy rate. And so while that hospital was clean top to bottom, while it was addressed, their business really went away. And if you've got a business interruption insurance and you deal with an extreme event or even a near extreme event, and your brand suffers, the insurer on that side is going to be very interested in making sure that hospital is high performing, has all the processes in place, and really knows what they're doing. And so we found an audience for what we're doing on the risk insurer side as well as the health insurer side, and we're working towards partnerships with them.
All right, and just from the sidebar here, I see you're going to be jumping off, Shahid, so thank you for coming in. We much appreciate it.
Thank you.
Have a safe trip back. All right. So, Dave, I'll turn to you. I assume that line of questioning there, or a line of comment there, had to bring some questions for you. So,
yeah.
What do you want to know?
Okay, I want to know, what gaps do you want to fill? How can the community that's listening to this bring help to you next?
That's a great question. I mean, I will follow back on what our original mission statement has always been. Our mission statement has always been to, reduce infections, like figure out how to wrap our hands around the problem of hospital-acquired infections as a niche that we're very good in, and reduce them and make hospitals smarter and better in the process. And we moved the company from Toronto to Buffalo 2 years ago, just so that we were in the U.S. market, that we were closer to what we thought our primary clients were going to be, and closer to engaging hospitals that we believe that time would have a stronger financial interest than hospitals in a single payer system, our home country in Canada. Where really there was no economic argument for patient safety. There was a moral and an administrative one, but the financial argument wasn't too clear. And it's been a very interesting learning for us being in this environment. The challenge as we move forward is, engaging hospitals that really do want to make a difference in the space. And do so, which is good for them financially as well as in patient safety and quality. And we have a few excellent partners here in Western New York, but we need to find more hospitals like that. And what we've been able to do is tie a partnership together with and take a second look at the challenge, willing to invest in innovation, and are really want to do something different to solve the problem, and being known to being part of the solution and not just a blockage. So I would say, we're always interested in talking to clinical and hospital leadership that have shown that they want to make a difference in that area and are willing to take a no risk approach to it financially, because we certainly want to work with you. We want to engage insurers more, and is probably in data discovery is the best way to put that. So if there's people that have access to data and are interested in sort of drilling into things and following some informed methodologies and suspicions and hunches, we would love to work with you as well and create partnerships there. The best thing about being an entrepreneur in healthcare, and is the community that develops around that. The biggest reward for us being here in Buffalo has been the support that the entrepreneurial community has given us. Our network and our connections, which have now, Buffalo is a hub, and surprisingly to us, and our connections have grown globally. But I would say, continue on that path where we're able to sort of grow that hub, grow those relationships, certainly around healthcare and innovation, and in our space, and keep building on solutions that are going to make a difference.
I have one more thought for you too about that, and that's that I just recently discovered how innovation programs work in hospital systems. Like down at NYU Langone, there's a person named Dee Dow who runs their innovation program, and one of the things she said to me is, we surface a lot of ideas from the NYU community by holding hackathons. Those hackathons can be great places to find out. They begin with a doctor, a resident, somebody like that inside of NYU Langone, surfacing a problem that's really important to them, to the extent that healthcare-associated infections come from or get recognized by or are the primary pain point of somebody who's participating in a hackathon. Might be a really good way to figure out who is experiencing that pain inside of a health system. So the startup community can also be good for helping to reveal these to you and surface them. Another question for you before we tune out, and that is, hey, one of the things that I've noticed from hearing your story is that you've built a product, put it out into the marketplace, measured what people did with it, started to realize there were inadequacies, had to change strategy, learned from that, and then repeated that cycle. And it's almost like you've delivered 3 or 4 different businesses in the span of Infonaut's life. For other founders who are out there in the healthcare space, what advice do you have for them about how to recognize when they have to change their strategy?
Yeah,
that idea.
It's lean. It's lean 101. There always has to be a question in mind whether you persevere or pivot. And being an entrepreneur, being an innovator in the healthcare space, certainly if you're dedicating a career in the space, I think is more of a gut check than it is, smarts. It's certainly, if I was to look back and what I try to help the companies that I work with now as an advisor and as a mentor is, how do we take that 6-year, time span of Infonaut? How do we make it 3 or 4? Time really becomes a lot more valuable in an entrepreneur's and company's growth when you're able to look back. And I think if we'd been smarter on the first time through and had not been first-time entrepreneurs, we would have made less mistakes. But a lot of it is, a lot of our learnings is because we've stuck in the market, we've persevered, we've found ways to keep going. And the insights that we're driving in the space, certainly around the business model, the financial, and the challenges with things happening or not happening, is only because we've put ourselves in the space, put ourselves in front of a lot of people, and have been asking the tough questions the whole time. So there's really no magic to it apart from, a gut check. And there's most of my friends say that, Niall, there's no way in hell I'd want to be doing what you're doing. And I can look them in the eye and say that straight back to them. Like, it's, we're having a good time what we're doing. It's certainly a little bit more stressful than any regular job, but it's worthwhile because we're on a mission. I think you also have to realize if you're in healthcare as well, I've had this conversation a few times. I've said if we were in big pharma and we were trying to invent a pill that reduced C. diff 5% or 10%, we would be in this for about 10 years. We would have raised like $10 billion by the end of it. And we would have had, a very significant award at the end financially, but, in terms of recognition, we're 6 years in. We're trying to do it as on an IT side. But our goals are the same as they were as any kind of pharma startup would be. In fact, we've got proof points now that our successes are much greater than sort of any leading drug coming into the market would be able to replicate. So we like where we're at. We like our mission statement. We certainly wish it was easier, but I think every entrepreneur, certainly in healthcare, wishes that it was easier. And we have to realize that we're not designing an app. We're not creating a widget. We're trying to solve a very complex problem, and we've got tremendous support for what we're doing. We just have to make sure that we're making smart decisions. We're getting into market as fast as we can, and anytime we hit a roadblock, we're overcoming that as quickly as we can. And maybe that's the best advice that I can give to any other healthcare entrepreneur that's out there.
Yeah, you touched on a really important issue there too, where the alignment's not there. Is, if you're doing the pharma thing, there's a whole bunch of money in treating an issue after the fact, but there's no money, at least historically, there hasn't been any money in preventing issues from occurring. Obviously that's the hope is that that's going to change. Value-based care, is supposed to kind of create space for that type of thing. So I guess two-part question is, one, how far off from seeing an impact of that do you think? Both for questions for both of you. Do you think we are before a startup might start to feel some of that and be able to benefit from some of that? And two, would you caution a startup away from even worrying about that at all because it's unpredictable? What's your take on that?
Dave, you go first.
Okay. I think it goes back to alignment, like we were talking about before. I think in the absence of alignment, you have to get a lot of, I'll call them coalition partners, people who who come from, yes, other complementary businesses that when any one of them succeeds, they bring you along, and when you succeed, you bring them along. So I think there's a huge role for finding those partners that can take you out into the marketplace, and vice versa. And Niall, who are those kinds of partners for you? What kinds of organizations tend to be partners for Infonaut in helping to combine together to realign the marketplace a bit?
That's great. Initially, we come from Canada, and the founders have worked within the Ministry of Health, which is, it's a single payer structure, lots of policy on the inside. If you make a decision at the top, then you slowly watch the whole ship turn. And because you have the financial and every other lever, you can get there eventually. But it is a very bureaucratic organization. That said, if you can engage government properly, certainly in healthcare, you can have the biggest effect most quickly, I believe. If the legislation and the policies are all set correctly and are based on evidence and are focused on making a difference for the consumer, who is often left out in the picture, then we can see some fairly rapid change. That's a huge undertaking for a small company to start making investments in lobbying and those types of things. We'll get there, but we'll be looking at that as a strategy for later rounds, and we'll make friends in government where we can. And the best way to do that is to show additional validation and proof points, and just kind of keep yourself in their face by showing successes. For us, I think a very important partnership going forward is the insurers, and that's why we've spent so much effort and time in qualifying their ROI. If I can have a significant effect on an insurer's bottom line by helping to make hospitals safer, then it's incumbent on the insurer, I believe, to act as a sales channel for Infonaut and help get us into those markets, and certainly put us in the hospitals that are experiencing challenges and are costing the insurer the most. That would seem the most obvious path. And so we're working towards those types of arrangements. We'll have announcements, fingers crossed, later this summer that will open up global markets for us in that regard. I will say that the one area that we have had the most recent success at a wider level is with the UK and the NHS. And from the systems that I have scanned and are aware of, I'll give you two examples of how the NHS has said, God damn it, we're stopping infections, come hell or high water. The first is in this budget cycle, 2.5% of all hospital revenues are being withheld from the hospitals in the NHS. And I believe that crosses almost 500 hospitals. And those revenues are withheld, and they can only be spent on infection control innovations. So a very quick way to avoid that procurement issue around startups and get money into the market quickly and make sure that hospitals are taking a chance is being validated, and come back after a year and say, okay, what worked? And that's a very quick response from the UK NHS. The second is they've also installed a director of infection control at every hospital. They are paid separately from the hospital trust, and that director has the power to advise the government they should fire or dismiss the CEO and the CFO because of efforts made around infection prevention control. That is an amazing statement to make. You are parachuting somebody into a hospital that has the power essentially to hire and fire based on what should be a number one priority. So an amazing way with 2 steps, and they're big steps, the government has focused the challenge around infection control in hospitals. And they've done it at the right level, and they've done it with a financial lever that I think makes sense. So there's an example of one entire system that has said enough's enough. We're going to set hard targets, and we're going to give our people the tools to do something about it.
Yeah, that's a really interesting approach with the 2.5%. And just saying, if I understood correctly, they're just saying you have to spend 2.5% of your budget on preventing infections. And then are they leaving it up to the hospital to decide which ones to attack and how to do so?
Yeah, there's 10 NHS hospital trusts that are seen as innovation sites. And so when you enter the NHS like we have and are introducing innovation, you want at least one of the participating hospitals to be an innovation site. So we have 20 regular hospitals, or 20 regular trusts, and 1 innovation hospital who will be validating the approach, not only that they see, but from the data that they collect from the other sites that we help provide. So if you don't spend the 2.5% on a hospital by hospital basis, it disappears next year.
Yeah.
So it creates a budget line and a budget item so that a hospital cannot say we can't afford it. You've got literally millions of pounds or dollars to spend on infection prevention control innovation. You can't just do the same old. Have at it and report back as in what your successes were.
Sure. And I'm sure there's still some regulatory issues that complicate that and make it sound less awesome than it sounds to me right now. But I love it so much better than saying, here's a goal that we're going to target, across all of the hospitals in the system, regardless of their current situation, because we're doing it centrally. We have to pick one. And then here's what you have to do, and here's how you're going to be rewarded. And then everybody's kind of forced into this funnel of trying to achieve something that might not make sense for them. If I have to spend 2.5% on it, I'm probably going to work on something that makes sense for my hospital and for my patients and my situation.
Exactly. And I think, I will contrast that with the experience that we had in Canada that has filtered down to the States saying, they embedded in legislation that staff are going to wash their hands and you're going to track compliance. One, it wasn't an evidence-based decision. It's a lousy metric. And it really, when you look at it, it has nothing to do with lowering infections. What it resulted in was every hospital reporting back that they were getting it right 98 to 100% of the time. And so you were fabricating results, you were fabricating data. And as a result, you skewed the incentive of everybody to spend all sorts of resources measuring a meaningless number. And then eventually, essentially what they were doing is making up numbers at the end. We got 98 hand hygiene compliance and our board gets a bonus of 5% because we hit it. Yeah, right. Well, you put a secret shopper in there, you monitor it properly, and it's between 20 and 30%. But hey, we hit our target.
That's interesting. All right, we're just past the hour here, so I do want to wrap up. For anybody who does want to get in contact with you or wants to learn more about Infonaut, what's the best way to contact you? What's the best way to learn more?
Infonautinc.com, INFONAUT, like an astronaut that sees information. As well, if there's any clinicians in the audience, we have a free risk, behavior, and culture assessment We're launched it globally. We have currently, after 1 week, 20 countries reporting in. We need a lot more users to get more meaningful data on just what is the culture of infection prevention control across the globe. We are presenting at the UK National Conference on September 6th, and then we'll be bringing back a roadshow to the United States and making sure that all the key stakeholders in our audience and our supporters have a window into what is the behavior and culture in hospitals that are preventing infections, and how do we use that information to do something about it. And I think it's a really, really unique piece of work. It's based on evidence we were gathering before, but I think the opportunity now is to take a look at it on a global level and see if the UK's approach is better than anybody else's. And this will be sort of the first time that those measurements are ever done.
Awesome. So there's an easy way you can help Niall and team out is go send out a tweet, everyone, right now that links to that survey.
Put it up.
Spread the word about that. That would be helpful. Well, thank you so much for coming. This was really interesting. Maybe we can come back and double back on it after you do your roadshow and everything, and we'll find out what you learned. Dave, as always, thanks for joining us and helping out. And everybody else, thanks for coming. Next week, we will... we're not sure what we're going to be doing yet. We may take the week off. We may schedule some. So keep your eyes peeled. We've got a bit of a scheduling conflict, but we'll see if we can work it out. And of course, I will update you all on Twitter. So thank you everyone for coming, and we'll see you next week or the week after.
Thank you, everyone.
Thank you.